My name's Claire Rickard and I'm a Fellow of the Australian Academy of Health and Medical Sciences. In my day job, I'm a Professor of Infection Prevention and Vascular Access at the University of Queensland and Metro North Health in Brisbane. Now, it's my pleasure to introduce you to Professor Caroline Homer, who will provide an acknowledgement of country and introduce our program today and our speakers for the first session, and I will be still here and back in the second session. Professor Caroline Homer, AO, is also a Fellow of the Academy, and she's the Co-Program Director for Maternal and Child Health at the Global Women's and Newborn Health Institute at the Burnet. Caroline has led research and development in midwifery, maternal and newborn health for more than 25 years in Australia and across the Asia-Pacific region. Anyone who knows Caroline knows that she has been a trailblazer and a champion in the development of nursing and midwifery clinician researcher careers, and I'll invite her to take the Zoom stage now.
Thank you so much, Claire, and a very warm welcome to everybody joining us this afternoon. It's super exciting for us to have so many of you joining us today virtually. I'd like to start by acknowledging country. I'm on Gadigal land of the Eora Nation and pay respects to traditional owners past, present and emerging, and particularly acknowledge that First Nations people were the first scientists, were the first researchers, were the first midwives and were the first nurses in our countries. And I pay particular, extend that respect to Aboriginal and Torres Strait Islander people joining us here today. We're so pleased that you could all join us, and we have some very special event supporters today that I'd like to acknowledge. The Australasian Nursing and Midwifery Clinical Trials Network are supporting this, and you'll hear later on from Greg Sharplin about the network. We also have some fantastic platinum sponsors, as you can see on the screen here, Murdoch Children's Research Institute, the Centenary Institute, the University of Melbourne, Barwon Health, Deakin University, UNSW, the University of Sydney and the University of Queensland. So really fantastic array of supporters. Thank you so much. We also have other program sponsors who are really supporting the Clinician-Scientist program, and you can see the names on the screen. But it's again really encouraging that so many organisations are really acknowledging that this space is really important. You may not have heard of the Academy before, the Australian Academy in Health and Medical Sciences that Claire and I are fellows of. This is one of 5 learned academies in the country. It represents health and medical science in Australia. We're an independent, interdisciplinary body of fellows. There are 475 of us, and we're elected to the Academy. And we put on a number of events, including this one, which we're very proud of. Some of the activities that the Academy undertakes is to advance research and innovation in Australia. We have a very big vision for better health for Australia and the world, driven by the best science. And we know that nurses and midwives are huge contributors to that science. And so this is part of this strategy today. And we're evidence-based, we're impartial, we're hopefully trusted, inclusive and sustainable. And these are some of our strategies that we think are really important to ensure that the mission, the vision of ensuring better health through research for Australians and for the global community can be achieved. So this is a really important activity, and we're so glad that you could join us. So there are a number of activities that the Life as a Clinician-Scientist are part of. There are fellows, there are awards, and we have policy to govern. So this program, this is the second one as Life of a Clinician-Scientist for nurses and midwives we've held. The first one was 2 years ago, and we had 50 registrants. Today, we have more than 200 of you online, and so we're super excited about that. What I think it shows is that nurses and midwives are absolutely committed to doing research. And that's not only because they want to further their own careers or get a better job or publish a paper. We know as nurses and midwives that being research inspired and research engaged means better outcomes for our patients. And we don't just know this, we know this from research. So there's very good research now showing that research active environments lead to better outcomes, reduced mortality, better patient experiences, more efficient and cost-effective care, and benefits to staff recruitment and retention. And at this time in our sectors, for nurses and midwives, we have to look after our staff. So whatever we can do to make that happen is important. So we've got some fantastic speakers this afternoon, all whom are trailblazers in their own way in leading nursing and midwifery clinical research. And I'm super glad to be able to introduce them all. The first is Professor Caleb Ferguson. I'm just going to stop screen sharing while I introduce Caleb. Caleb is the Professor of Nursing, Chronic and Complex Care with the University of Wollongong, and he's Academic Director for the Centre for Chronic and Complex Care Research at Western Sydney Health. So he has this fantastic dual role within the health system as well as a university appointment. And I have the privilege of knowing Caleb since he was very early on in his career as a PhD student, and it's been an absolute pleasure to watch his progression over these last 15 years. Caleb has one of the NH and MRC Emerging Leadership Fellowships, which are hugely competitive and hard to get. He's got expertise in translational research methods and implementation science. He's a registered nurse, a fellow of the Australian College of Nursing, and a wonderful speaker. And we're really looking forward to having Caleb join us. There's one other person I have forgotten to introduce, and that is Debbie Wood. And Debbie is a very talented graphic recorder, and she's going to join us through this event. She's creating a graphic and visual representation of the main points covered throughout the session. Debbie's not going to talk about the science that we present in terms of the work of nurses and midwives. She's going to record the process, and we're really excited about that. There's question time at the end, and we hope that you'll be able to put your questions in the chat box as we go along. So without further ado, over to you, Caleb. Looking forward to your presentation. So just go into screen share, the slideshow mode. That's it. Perfect. Well done. Thank you.
Thanks so much, Caroline, and thanks so much for the opportunity to speak today and to share some of the insights as life is and my work really as a clinician-scientist. As Caroline said, I've known Caroline for quite some time since working at UTS as an associate lecturer, and just recently I was appointed as Professor of Nursing in Chronic and Complex Care to lead a new collaborative research centre between the University of Wollongong and Western Sydney Local Health District, with a scope really around chronic and complex care in Western Sydney as well. I'd also like to acknowledge my team. So Julie and Sabine and John are all three postdoctoral fellows that are working with me. Scott is a project officer, and Rija, who's our nurse specialist. And also we have 7 PhD candidates as part of our newly established centre at Blacktown. And I'll tell you a little bit about the centre as we move through today's session as well. So for those of you that don't know, this is the new sort of build of Blacktown Hospital, which is just absolutely beautiful, and it's a real privilege to work at this hospital. It's gone through quite a massive transformation in the last probably sort of 5 years, I would say, with really a really massive increase in capacity. And Blacktown is part of Blacktown and Mount Druitt hospitals, so it's actually 2 sites, which are on 2 different locations, but it comprises of around about 500 beds, and it's around about 30 kilometres from Sydney CBD to the west. And it's beautiful. The story of the background of these colourful window panes is really to reflect the diversity of the population which the hospital serves, and it's a beautiful campus to work on as well. We've recently moved into some beautiful space as well, which is located right in the middle of the hospital, and which is a real advantage when conducting clinical research with patients. And I think location is really important, and having that visibility within the hospital, being a nurse researcher as well in that clinical environment. So I wanted to spend a bit of time today really talking to maybe contextualize some of the work that I do as a clinician researcher. But I'll only spend a short time really talking about two major projects that I have underway at the moment. And then I wanted to spend the last half of the talk really providing some comments and really sort of insights into the life of a clinician researcher and how to really sort of optimize your time in the role, but also some of the key challenges and maybe some of the solutions that I've applied to the role as well. So I've been in Western Sydney for the last 5 years. I commenced there as a senior research fellow in a conjoint position. And I've also recently, I was an associate professor for a couple of years in the same centre before moving to the University of Wollongong as well, where I've just taken up this new position. So my clinical background is as a stroke nurse, and I've worked in acute stroke units across sort of Greater Sydney for quite some time. And I really was quite interested in atrial fibrillation, which is a major risk factor for stroke. And it's really often present in around about a third of all of our stroke survivors, people who have ischemic stroke. So it's a major risk factor for stroke, something that patients can do something about. But I guess it presents quite a significant problem in terms of diagnosis, but also treatment optimization. And the fact that these patients will take anticoagulation for a very long time, often lifetime duration. And a lot of my research is really focused around medication adherence to anticoagulation. And for a long time, I really thought about if patients were more equipped with the knowledge that they might adhere to these medicines a lot better. But working in the stroke unit, some of the common approaches that we use to educate our patients really are a bit substandard. So we give them things like anticoagulation brochures and written materials, which are now quite outdated. And a lot of patients seek advice from the internet, from Dr. Google, which can sometimes be quite substandard in quality as well. So I was really fortunate, as Caroline mentioned, to receive an NHMRC Emerging Leader Fellowship, which is a 5-year competitive fellowship from 2020 to 2025. And really to devote a lot of my time to this project in particular, which is called Inform AF. And this is a collaborative research project between the university and the health district. And I'll tell you a little bit about some of the pilot work, but we're just starting to recruit for a randomized controlled trial as well, which is really quite exciting. So we undertook some qualitative research to really look at the standard of education and self-care in people living with atrial fibrillation. But we really found that there was a lot of scope for improvement in this area. The timing of AF education was often quite problematic, and the quality was, in terms of the credibility of the information, was quite variable as well. So the really provided scope to really sort of focus in on this problem and think about some innovative solutions of how we could improve patient education and self-management in this high-risk group as well. So I've been working with this technological product, which is called QStream, which is a product that I previously trialed in some of my earlier postdoctoral work that really looked at educating nurses around about atrial fibrillation and anticoagulation. And we found that using it with nurses in 3 hospitals and 4 clinical units improved their knowledge, but also risk assessment of patients when it came to stroke and bleeding risk as well. So a logical sort of next step in this research program was to trial this with patients and to see if that improved their knowledge, but also some self-care behaviours and medication adherence and so on. And did this lead to improved patient outcomes? So for the last probably about a couple of years, we've been looking at developing this module and co-designing this intervention with patients based on this qualitative work that we had conducted previously. And we've developed this module, and we've just conducted a pilot study, and I'll present some of the results in the next few slides. But here you can see the patients are delivered an app-based intervention, and we recruit these patients directly from the clinical area at Blacktown and Mount Druitt hospitals. And they're provided with a series of questions. It's an interactive module, and it's provided over a 6-week period. It's a theory-driven intervention, which is shown to improve long-term knowledge retention, but also some behavioural impacts as well, which is quite exciting. So the module consists of these 6 key areas, looking at signs and symptoms, risk factors, complications, medication management, and also lifestyle management, and when to seek assistance as well. So we delivered this to patients' smartphones over a 6-week period, and we followed up the patients at 6 weeks, 3 months, 6 months, and 12 months as well, to look at patient outcomes as well. We phoned them to follow them up, and this showed really quite good results as well. This is from the back end of the platform, really showing that these domains of risk factors and symptoms and when to seek assistance were the areas in which they improved their knowledge quite significantly as well. We were quite interested in these outcomes in particular, so AF knowledge, but also quality of life. And we also conducted some assessment of system usability, which was rated as excellent. So we showed that we were able to improve AF knowledge and quality of life at 12 months, which was quite exciting. And we've since been successful in securing some more funding from the National Stroke Foundation, from the Nancy and Vic Allen Fund, to progress a randomised controlled trial of this, which we're just commencing recruitment of at the moment as well. Looking at some different outcomes that are particularly important to patients. So the second study that I wanted to briefly discuss was this, what we've called the Western Sydney Clinical Frailty Registry. And this is an initiative that I co-lead with Professor Richard Lindley, and it's quite a collaborative research project across a number of universities, so the University of Sydney and Wollongong, and the Health District as well. And this was an investigator-initiated research in the Rehab and Aged Care Department at Blacktown and Mount Druitt hospitals. And it's currently ongoing, and this is a 5-year study recruiting patients from the Rehab and Aged Care Department and following them up over time. So this is not particularly fancy. It's a clinical cohort study with opportunity to do data linkage as well. But we're really keen to know what happens to our patients, what was the impact of frailty in the long term, and look at some other quite exciting measures as well. So we've published this protocol in Collegian, and the idea of this also was around capacity building in terms of research, clinical research capacity building in the hospital for nursing and allied health in particular. So we talk about developing a spine research project, and this provided the opportunity for us to have small projects that had ethics and governance approval that could nest within the registry project itself. And an example of this, Kirsten Parker is undertaking her PhD with us at the moment, and she's looking at transitional care for those patients from the registry itself. And the beauty of it really is that we have the outcome assessment already set up to do now a nested trial within this cohort study itself, which is quite neat. I wanted to briefly talk about funding, because I think this is a really critical part of doing clinical research. And obviously you need the time and the resource to undertake clinical research. And I wanted to acknowledge, I think, really the funding that I've had previously to support myself through fellowships, but also project funding as well. And I really think that immediately post-doc, I went back into a blended teaching and research position, but was really fortunate to receive a UTS Chancellor's Postdoctoral Research Fellowship, which really provided me with some protected time to advance my research programme, and which really also underpinned the success in Heart Foundation Fellowship and then NHNMRC as well. I guess what's not listed here as well is the long list of unsuccessful applications, and I think for every successful one, there's probably been about 10 or more unsuccessful grants as well. But I think, you know, being in the clinical environment really provides you with the right sort of area to support your clinical research with patients and as well. So this is some of the team that are involved in the clinical frailty registry. So Fahad, Julie, Kirsten, Rija and Sabine. And this is in our beautiful new space in the hospital as well. I'll just briefly, for the next sort of 5 minutes, highlight some of the capacity building work that we've been doing at Blacktown as well. And I think this is really core to, I think, my purpose within the health district. And I really love the ability to walk into work and pop up to awards and to see patients and to recruit patients into studies, but also to engage nurses and midwives in research as well. And so as part of our centre, we run quite a few capacity development activities, such as writing workshops, but also journal clubs as well. And these are some lovely photos from quite a while ago now, when I first started in the district. And this is the Westmead Neuroscience Nursing Journal Club as well. And I think, you know, engaging with external partners like the Stroke Foundation has really been an advantage to my work, and something that I've really fostered over the more than a decade now of doing research and really engaging with them as well. So I wanted to sort of wrap up really by offering some suggestions as well in terms of some really core principles around success as a clinician researcher. And this is by Ferguson, which is not me, in 1993. But they offer these 10 essential principles for what they call effective political action. And I think that these are really quite important points that I want to spend a little bit of time talking about. So I think as a clinician researcher, we often really need to think about the big picture and the long-term vision and mission for our work as well. Sometimes we need to really do our homework and thinking about sort of the political circumstances of the health system and the university system, which can be often quite challenging to work across the two organisations as well. Sometimes, you know, this analogy of half a loaf is better than none. So, you know, if you're applying for a $50,000 grant and you don't get that, but someone is willing to provide 10,000 sort of Kickstarter funding, then that might be really advantageous to really kickstart some of your work as well. I think really understanding the sort of political landscape across the health system and the universities is particularly important. Sometimes it can feel like a bit of an alien in both organisations and working between the two. The university thinks that you're never there and you're not really sure what you do, or the health system thinks that you're always at the university. And this can often be quite a challenge working across both organisations as well. An example of this also might be around delivering on research outcomes. And sometimes the health system might expect quite immediate outcomes on research, and really sort of understanding this analogy again of Rome wasn't built in a day, and that research often takes time. It's a very thoughtful, planned activity. It's often quite high risk as well in terms of not knowing what outcomes that there will be, and quite an investment of resource, time and energy as well. But some of these studies take quite a long time to conduct and won't lead to really immediate outcomes within the health system as well. So it really does require this long-term vision and quite big picture thinking to achieve as well. So So lastly as well, I wanted to really just plug, we've been working for quite a while with Sphere, which is one of the Sydney-based research translation networks, which is led by Professor Sandy Middleton and myself, and really wanted to also acknowledge the hard work of Professor Marie Johnson, but also Anna Thornton, who's the Director of Nursing at St Vincent's Hospital in Sydney as well. We've been working for quite some time, recognising the need to develop clinician researchers in capacity in nursing and midwifery. And we have recently just published a paper in Collegian, which is just online actually yesterday, in press, which showcases the nursing midwifery career pathway. And this provides an opportunity for buyout time and training opportunities from levels pre-doctoral right through to postdoctoral and professorial as well. And we look forward to sharing some of the outcomes of this project in the future as well. And so again, I think it really takes a team to be successful as a clinician researcher, and I wanted to really acknowledge the hardworking team as well. And also on the left-hand side is Helen Abuyani, and Helen's the Director of Research Operations at Westmead and part of the Research and Education Network. And it's people like Helen and her support that are really critical to success in these roles as well. So I really want to acknowledge the Health District's support over the years as well. So I'll wrap up there and look forward to some discussion. Thanks so much.
Caleb, thank you so much. That's just wonderful and a perfect start. For me, the take home was you've got to have an important problem to solve. You've got to be collaborative and multidisciplinary and find good leaders and good mentors. Be very resilient. My list of unsuccessful grants is 100 times longer than the successful ones, and have those professional links. And I think your comment about the Stroke Foundation was great. We've got time for one question. If we could go back and ask young Caleb some advice way back when you were, before you even entered university, about your clinician-scientist career, what would it be?
It's quite difficult. I think there's two things, I think, Caroline, if it can be greedy. One is, I think, to not give up on clinical. I think that often people are really keen to advance research in educational research or professional research areas, which are really important. But I think often people see clinical research as a nurse or a midwife as often very challenging or too challenging and too risky. And so I think we really need to promote this as a really vital career option, and to sort of really showcase the success of others in that area as well. And I also think just sort of like you said about the network of people as well, not being afraid to reach out for mentorship of others, and really surprised, I think, over the years at the generosity of others in academia and in clinical as well. It's not just about really having one mentor. I've found over the years is that you kind of have this sort of network of guardian angels, if you like, that you can tap into quite a lot as well. So I think, yeah, as you mentioned, really having a supportive, collaborative network of people and really fostering that over the years has been a really important piece to success. Yeah, thank you.
Fantastic. Thank you so much, Caleb. We're going to move on, but I hope you can stay with us for the afternoon, and there'll be opportunity for more questions at the end.
Absolutely.
And I hope you can see Debbie's recording of your conversation, which is just lovely, and some really fantastic messages there around time and funding and finding your people, and yeah, just lovely. So thank you, Debbie, for doing that with us. It's great. Okay, our next speaker, I'm very happy to introduce you to, is Lauren Kearney. Associate Professor Lauren Kearney is the Head of Discipline for Midwifery at the University of Queensland. She's a registered midwife and nurse, and she has a conjoint role again as Associate Professor in Midwifery between the Women's and Newborn Services at the Royal Brisbane and Women's Hospital and the School of Nursing, Midwifery and Social Work at the University of Queensland. So another one of these fantastic roles. And Lauren has strong industry collaborations, has had a number of competitive research grants in maternal and child health, and she's passionate about improving the experience of healthcare for women and children through getting evidence into practice. So a completely perfect speaker for us this afternoon. Over to you, Lauren. Thank you so much.
Thank you so much for that warm welcome, Caroline. I'll just get my screen ready to share here. Are you seeing my slides or are you seeing my UQ Authenticate?
No, we're seeing your slides. We just need to go into
slideshow.
There it is. Great.
We're good?
Done.
Okay, great. All right, thank you so much. That was an excellent presentation, Caleb. I think there's a lot to learn from what you have shared with us, and congratulations on that fantastic work. I am very delighted to be here today. As Caroline mentioned, I'm an associate professor in midwifery, and my topic today that I've been tasked with is balancing the many roles of a clinician-scientist, and Caleb actually touched on a few of those areas. Thank you for the opportunity to talk with you, Caroline and Claire. Thank you so much for the trailblazing work that you have done for nursing and midwifery in our professions, because we're following in those footsteps, and they've been hard roads to build, and we're still building them. So I'm looking forward to chatting with you today. So I'd like to start my presentation today with an acknowledgement of country. I'm meeting you today from the lands of the Turrbal and Yagara people, the traditional custodians of the lands around the Brisbane region. I'd also like to acknowledge the Gubbi Gubbi peoples, the traditional custodians of the lands where my family and I live. I want to acknowledge elders past, present and emerging, and acknowledge how much I have learnt from my First Nations friends and colleagues in midwifery. So as introduced, my name is Lauren. I'm a registered midwife, I'm a registered nurse, and I work in a conjoint position similar to Caleb. My office is also in a hospital in the Royal Brisbane Women's Hospital, not quite as pretty as Blacktown's new build there, but fantastic that I have forged space inside the main building. So I was thinking about the presentation today and the many roles that I have here, and my presentation is going to be a little bit different. I thought I would share with you a little bit of what it's like wearing numerous hats. I'm also a mother, and I'm going to reflect on some of that journey with you today. So as Caroline mentioned, I'm the discipline lead for midwifery at UQ, and part of that role is really to advocate for our students, for our profession in a large university sector, and ensure that we have a voice and that we do the best that we can there. I'm an active clinical researcher. I love to work with priority population groups, respectful maternity care. I'm really passionate about midwives and our collaborators' opportunity to really improve spontaneous vaginal birth. And I'm doing a couple of big projects at the moment on workforce. My role is also around building industry and tertiary sector linkage and partnership, and this is so critical for us as midwives and nurses. There is a lot of pressure when you're a clinician and you go on to do a PhD to enter a career in academe. I also did that for a time, but it's not my happy place. My happy place is back here in a conjoint position. It is difficult, and I'm not going to lie and say that it's a smooth road, but I learnt a lot when I was back in my balanced academic role. I do some teaching and learning now in my current role, and I've just been working on the development of a new midwifery leadership course at UQ. Another bit of an area we're growing here at the Royal is around our student placement, our undergraduate nursing and midwifery students, and how we can get the most out of their clinical placement opportunities. And I also, of course, have other hats that I wear. You know, we review journal articles. I'm an associate editor with Women and Birth, and various other things. So this meme is quite funny to me. This is often how my life can look. I'm very busy and I don't always have pure balance, but I want to share with you today some of the great things that I've learnt. I have maintained clinical contact until last year. I kept a casual position at my local hospital working in birth suite, and that was a really key part of me wanting to work in research, was what I've learnt from clinical land. I want to go back. I'm just in a time where I'm working in a purely academic role, and I think we've got room to work as a profession to enhance how we maintain clinical contact in midwifery and nursing. My original conjoint research fellow role had a 30% clinical load, and I loved that. So I know it can be done, and I think it's an area we can grow. So balance, the topic of my presentation with you today. It's a really interesting thing. You know, it's something we often strive for, which means that we're often not in a state of it. The dictionary defines it as someone or something that we're trying to remain upright and steady. It's often easier said than done, isn't it? So how do we stay there? How do we get there if we're not there? And so I think too, the selection of this topic of presentation sends a message from the organising committee that maybe this is not something that we do particularly well and that we can learn to do better. And I'm a perfect example because I don't always get it right. And I'm going to be really honest with you. And it's a bit like the grants, you know, all these unsuccessful grants, we learn so much from them. And there's so much that we can do to move forward. So as I was preparing for the presentation, I did what all diligent clinicians and researchers do. I thought, oh, I'll just go to the literature. I'll go to a textbook. I'll look up, you know, some evidence around how to balance multiple roles as a clinician-scientist. And, you know, well, of course, there is no textbook on this. There is no instruction manual or systematic review for me to share with you today on how we do this. But what we do is we work it out as we go along. We learn from those who've gone before us, we seek advice, we take advice, and we move forward. Nurses and midwives are really good at this. We have to be flexible in our roles, we have to pivot, we have to change, and we have to work things out as we go. And so we bring all of that clinical expertise into these new roles as clinician scientists. So in the absence of high quality literature to guide my presentation with you today, I thought I'd share a little bit about my story and some key learnings that I have gathered along the way in and out of clinical research roles. So I set out into my nursing career in the mid-1990s in Queensland. That was before you could do midwifery directly, you had to do nursing first. I'm not going to lie to you, I had a really romanticised view of this profession, and to be honest, that was quickly introduced into quite a different reality. No one at all in my family or my extended family were healthcare professionals, and certainly no one from my family or my extended family had been to university. So at that time, I was really excited to get into university and to learn how to be a nurse. I was still informed at that time, though, that universities probably weren't the best place for nurses to be educated. And thankfully, I don't think that's really the narrative that we hold today. So we are making really good progress as a profession, as an industry. The vast majority of my career has been within midwifery, paediatrics and community maternal and child health. And again, as I said, this is my happy place. This is where I like to work. This is my population group. I really care deeply about women and their families during the reproductive years. And I think midwives have such an important contribution to make in their lives during that time. I also have 3 children. We often joke with a friend of mine, it's just sort of one too many, but I'm so grateful for my kids. I had midwifery continuity of care for all of my babies and through my local public hospitals. My last one, I was working there as a midwife when Thomas was born. And I want to start, move to this next section of my presentation by sharing a little bit about that 3rd pregnancy and the birth. So this is Tom. He's currently 6 years old, and he was born at 34 weeks gestation with severe intrauterine growth restriction. This is him here. You can see him snuggled up. That's just after my cesarean. I'd had 2 previous vaginal births with my girls, and I just want to start here by saying that clinicians asking questions, generating evidence, establishing management guidelines, implementing high quality evidence into practice means that Thomas is alive today, that he's well today, and as am I. Thank you, science. Thank you, evidence-based midwifery care, and thank you, collaborative and respectful obstetric and neonatal teams, because without them, that might not be my story. So how does this relate to balance and the multiple roles that we juggle? I don't think we can disentangle our home lives and what we do as human beings from our work. So I just wanted to put that out there for a start, but it also takes me to the first point that I wanted to raise around maintaining balance in this role that we have as clinician researchers. And that is, of course, looking after yourself and your loved ones, and this must always come first. So the week that Thomas was born, I was still rostered to work. He was born on a Wednesday. I was meant to be presenting at a conference on the Thursday. I'd successfully been awarded quite a significant grant. And so there's no real prizes for guessing what I did at that time. I immediately started maternity leave. I withdrew from the speaking event. I withdrew from the grant and project altogether because of the timelines, and I was not going to be able to commit to that at all. And I knew that at that time, my prioritization in order to maintain balance in my life and for my family was to grow and nurture this very small human that I had been gifted. So not only in times like this that we all go through, where we have crises or we have really difficult situations, but we need to be mindful of ourselves, of the sustainability of our roles as nurses and midwives, whether we work in a clinical environment, an academic environment. The demands are big, the demands are growing, and I would encourage you to really stop and be in tune with your body. And when things start to bubble up a little bit, what are your signs? Think about them, protect them, listen to them. Protect your sleep is something that I really work on. Protect family time, spend time in nature, do what makes you happy. Because in order to maintain balance in this chaos that we've invited in our careers and what we gain so much from, we need to also acknowledge these things. So point number 2 is around prioritization. And I know I'm not going to be telling you anything particularly new today, but I think it's a nice reminder of what we can do when things feel like those squirrels at a rave. So prioritization, there will always be more to do than can be done. That will never change, and it's okay to sit in that. It's okay to be okay with that. Prioritization is a key strategy that I use. I write lists and I cross things off lists, and that helps me to feel like I'm making progress and moving forward, when often projects that we are involved with as clinician researchers go on for years. So my role here at UQ is relatively new. I started here 1.5 years ago. I came from I'd been in a conjoint, then I went into a balanced academic role, and then this position became available, and this was a big growing moment for me. But when you're entering a big institution like the Royal Brisbane and Women's Hospital and Metro North Health, which is one of the largest health services in Australia, it's really important to start thinking about, how am I going to manage all of this? How am I going to maintain some balance? So a couple of my amazing colleagues and I started thinking about what we could do to prioritise what we do. So many of you will be familiar with this. This is the James Lind Alliance, and I just wanted to provide this example around priority setting. And so this is a framework that was developed over in the UK, and it's really purpose is to bring consumers and clinicians together to identify and prioritise unanswered research questions. And so we decided we would do one of these. We applied for a small $50,000 grant, which we were successful in, and we undertook this really rigorous process of talking to clinicians across Metro North Health, and it was also the Sunshine Coast region, which is our neighbour. Up here, there's 5 maternity hospitals across those 2 hospital and health services. And there's obviously varying research that's going on, but as a new position and as a new clinical academic here, it was really important for me to get a handle on what the priorities were. And so we worked through each of these stages. I won't go through each of them with you today, but a couple of highlights from this. These are the cards that we presented at our workshop, which I'll share with you in a minute. But this was a really important topic of conversation for consumers and for our obstetric, midwifery and allied health respondents to our survey. So how it works with James Lind is that the healthcare staff rank what is most important to them, and then the consumers rank what was most important to them. As you can see, consumers and healthcare staff ranked this as the most important research priority for our health area. I have a bit more of a story to tell you about that, but I remember how much I nerded out with my beautiful nurse research colleague and an obstetric colleague who I was working with on this, that, you know, these two things really landed around how can we optimise normality for women when they're having a baby. These are some pictures from the day. So we had a workshop at the very end of the process where we had to bring, there was about 40, I think, at the end, top priorities. And as a group, we had to decide what we wanted to set as our top 5 priorities. And I think this is a really important process. It's just local to us at Metro North Health and Sunshine Coast region. But coming into a role like mine, it helps give me some direction. It helps give me a bit of a compass to pull research and interested clinicians and consumers into a bit of a direction in which we can take. These are our top 5. As you can see, the safely increasing spontaneous vaginal birth actually moved down to 2nd, and that was after a lot of really amazing discussion on the day. We had equal representation across consumer groups and health groups, and it was really felt that the maternity care experience and engagement outcomes of our priority populations, and they also had a clear definition around them, needed to be the first thing that we were working on. These questions are quite exploratory in nature, but that's what our community wants us to do. And so this helps me to have a compass to drive over the next 5 to 10 years in this role. So my next point around maintaining some balance is to really know where you're going, have some direction and some interest, and bring others along for the ride. I'm a real people person. I love to work with colleagues. Nurses and midwives are notoriously funny, and I think embracing that humour, you know, being who we are is okay. So this was a clinical midwife who I've worked with for many years, and she's recently made a transition from being an academic, from being a clinician to a teaching academic, and she's embarking on a PhD. So she came and saw me and said, "I'd love you to supervise me, Lauren." And I said, "Look, Anna, I've got a heap of great projects. I'm going to give you a few of these topics, and perhaps you could just choose an area if you're interested. Otherwise, go and speak with many supervisors, get many ideas about what you want to do." So I'm embarking on a really exciting program of work around caring for larger bodied women. And so Anna's decided to do her PhD in that topic, and she found some gaps in the literature around what she wants to look at. This was a text message she sent me on Monday about how much fun she was having in Covidence. So all the researchers in the room go, "I'm winning. If my PhD students are having fun in Covidence and learning new skills about synthesizing literature, I'm happy for that." Another tip that I've learned that is, if you are a teaching academic, which many of us are, it's really good to align your teaching with your research. If you can do this, because we want to make the most of our time, make the best of it. So if you're interested in water immersion and water birth, then try and pick up the teaching units in that area. If you're interested in the care of the complex woman, then try and align your teaching and your research as much as you can in those spaces. You know, as we grow older and as we move further into our careers, having difficult conversations is also something that I think is important to maintain balance. You know, the further you move through your career as a nurse and a midwife, if you're entering a career as an academic or as a clinician-scientist, having difficult conversations is something you're going to have to do. It often involves things such as no. I'm a yes person, but as I've got a bigger workload, I've had to start saying no a little bit more. It's okay to say I need some help. It's okay to say I respectfully disagree with you and find a solution together. Sometimes collaborations need to finish because your circumstances might change. These things are all okay. I think having some self-belief, do it afraid. You know, when we're forging new roads, when we're trying to do clinical research, it is scary and it is hard. So swallow that imposter syndrome and just get on with it. You can do it. this is just another point that I had, you know, as a clinician scientist, we're always working to that next big thing often. You know, this is a long game. I think Caleb said that as well. Being a clinician researcher is a test of your patience, of your perseverance. You're often thinking the next big grant, the next big publication, a collaboration. But I would encourage you to really celebrate the small wins as well. There are going to be small wins, like when Anna sent me that text. The joy when you learn something new, or you teach something new, or your manuscript goes out for review, when your colleague wins a grant. Celebrate those things. Some strategies around helping with being in the moment. Turn off Outlook. You know, it's okay to have your notifications off for a little while. It's okay. People will ring you if they really need to talk to you. Set regular sets of time aside where you can really think about what you're doing. You know, is this the right path to go with this research question? And these things take quietness and time and contemplation and review. And so give yourself permission to do that. So find your people. And look, I think Caleb also spoke about this. Teamwork is so important. You know, my fellow nerds that I love to call and friends that I have across midwifery and obstetrics and allied health and just my school friends who are teachers and other jobs. You know, it's good to have your people around you to support you and to cheer you on and to be so excited for you when you win a grant or you get through your next module of study. Be gentle and kind with each other. This is a tough game. We have to support each other. We have to be there for each other. And I think we've all got some people in our life like this. And if you don't, then, you know, I'd encourage you to try and find some. Be brave, go and talk to people. Most people are very friendly and happy to share their learnings with you. And then prioritise time with them to maintain some balance. I've just got a couple more slides here now, but one of the other thoughts I had is that sometimes we think that balance and control are the same thing, that in order to maintain balance, I need to be in control of all of those things that are happening around me. And that often we can't do that. It's very hard to do that. There are things in the science journey that you can't control. How long a governance contractual agreement is going to take is often out of our control. The COVID pandemic is a perfect example of when things are going to happen, and we just have to pivot. We have to do our best. When we're caring clinically for a woman in labour, we've got a particular outcome that we all want, and it doesn't happen. It's okay. So I think you can maintain balance without always being in control of every little part. You can't choose how other people are going to react to you. You can't choose their attitudes or behaviours. So I would encourage you not to give that any oxygen. Focus on the things that you can do, because you can make progress, even if it's slow. I think the other thing is really centering about why am I doing this? You know, when we have these moments of self-doubt, when we get another paper rejection, when, you know, all the things that you're going to critique is an everyday experience of a clinician scientist. You know, your papers go out for critique, your grants go out for critique. It's just the way it is. So keep the people who you're doing this for right in the middle. A very wise manager of mine who we lost last year said to me, Lauren, if you just keep the woman in the middle, everybody comes to the party. And it works. You know, if you're having a disagreement with someone, just put the woman in the middle. What is best for her and her newborn at this time? This is my middle child, Eden, dressed up in my scrubs from a number of years ago. But, you know, my experience is different. I am a woman. You know, I think about my daughters. I think about the future of sexual and reproductive health for them. Gender inequity is a real thing. It's hard balancing not only our professional responsibilities, but also the unseen huge role that we have as partners, friends, daughters, mothers. And so just keep them in mind as you keep moving along. So thanks so much for listening today. I hope on some level this has been helpful for you. I don't have the answer. I don't have my ducks in a row, but I'm still here. I'm still going. I still love my job. I still believe that we can really make a difference in what we're doing, even if for some of it's a slightly slower road, just to maintain that balance. But thank you.
Lauren, thank you so much. That's just great. And I loved the balance and you know, it feels like taking your whole self to work when you kind of bring in the other bits of your life that are not
Yeah.
just your professional life. And I think many of us struggle with trying to keep them separate. And I think you've just provided a really great example of not struggling with that. In one sentence, a question: how have you learnt to be okay with not getting it all done?
Oh,
I reckon there's a lot of that in there, isn't there?
yeah.
So,
I'm not always okay with it, I'd first say. You know, sometimes it overwhelms me and I think, golly, I'm slow, I'm not getting this done as quickly as I need to. But yes, that's okay. I just breathe it out and I think about what's really important at those times. And so that prioritization comes in. What do I actually need to do today? What is the most important thing on my list? Is probably what I do, and I try and just achieve that one thing. And even if it's just one thing today, then I'm okay with that. Yeah.
great. Thank you so much. I hope you can stay with us. We'll probably have some more questions at the end, but a huge thanks. That's just a terrific presentation. Really lovely to have you join us. So our third speaker before we have a short break is Professor Donna Hartz. Donna is the newly appointed Clinical Chair in Midwifery at Western Sydney University. She comes to this role with many years, she's told me 40 years, it's probably about that long, years experience as a clinician, educator, lecturer, manager, researcher and consultant, and I've had the privilege of knowing Donna for many of those years. Donna identifies as a descendant of the Kamilaroi people. She's got extensive experience in maternity care, service redesign, caseload midwifery, birthing on country, Aboriginal breastfeeding support, and a whole range of just wonderful work. And it's so terrific to see Donna now having this clinical role in Western Sydney where, you know, the need is so great and the leadership is so needed, as in every health service. So Donna, a huge welcome and lovely to have you with us this afternoon.
My absolute pleasure. I'm honoured to be invited and amongst such learned younger colleagues. Can I say thanks for pointing that out, Carolyn?
You must have written it somewhere, Donna, but I think it's the same. So we're in good company.
There we are. So how does that look? Does that look all right?
Yeah, that's perfect, Donna.
Great. So I'm just honoured to be here. And you're right, I've just started. This is week 3 and my feet quite haven't touched the ground. And I am just honoured to be the inaugural chair of midwifery at Western Sydney Local Health District and a professor at Western Sydney University, which is one of the many universities that I've worked at over the years. Has been called a bit of a university floozy in my time. I've been, I think, to most of them, most recently Newcastle and UTS, and as you'll see, Sydney University as well. So I want to acknowledge the traditional owners of the land that I'm sitting on today. I'm down here at Blacktown Hospital. I co-locate with Caleb Ferguson, so I'm sure you're sitting across the other side of the campus at the moment, Caleb. And there's the Darug people, so the elders past, present and emerging here. And I want to pay respects to my Nana's family, the Kamilaroi or Gomeroi people from Binaway and Kearney, who have really influenced a lot of the work that I'm doing now. This is a beautiful picture. I went up during COVID and did some, so as a clinician, trying to do some clinical work, went up and helped with vaccinations up in Walgett, which is Gomeroi country, and that was an absolute honour. So this is an Amoi River in flood, and I just loved the fact that this was classic dattery where we just, it's reflection. If you look at the perfection in that, and we'd go down and think about you know, what was going on the day, what the impact we were having, what the community, what impact they were having on us as well. And I think this presentation is a little bit about that reflection. I'm going to take you on a journey of myself as a clinician and then into a researcher. So coming back to Blacktown, I was a little girl that grew up in Mount Druitt, a little, you know, there I am playing netball for the Tregear Foxes. So I feel absolutely honoured to come back out. I was one of the first high school students that went through Wellin High School in Mount Druitt, and we were never expected to be anything, you know, we were never encouraged, and most of our teachers, as well-meaning as they were, didn't aspire for us to do very much. So, you know, Mum said I could never go to university because I could never afford that. And so a little girl from Mount Druitt, I saw a lot, and I've never forgotten. And in fact, there's one of my beautiful Aboriginal sisters there, who's at the back, and Dee and I still do work together in research now after 50 odd years. So, and here I am now back at Blacktown with covering. So that's my competing picture there, Caleb. You showed your building. Oh, this is our gorgeous Western Sydney University Clinical School, where myself and my research team will be based. And what I love about being here now is that not just grew up in Mount Druitt, I had my first baby here. So she's now touching 40. And then my patch out here at Western Sydney is Blacktown Hospital and Mount Druitt. Some outreach there. Westmead, where I did my general training. Blacktown, where I did my general training, had my first baby. Westmead, I did my midwifery training there. And then I also am blessed to have Auburn in my patch. So there's some fabulous work to be done as a clinician-scientist now. So I ended up doing certificate training nursing. I went to university, but we weren't trained at Mount Druitt to go to university. We were with all the private school kids. It was free. Thank you, Gough Whitlam. It was the first year that we could go and do academic studies, but we were ill prepared. And I ended up, leaving after a year and a bit, and ended up doing my nurse training and then my midwifery training. And it was those that once I did my nursing, and then I was accidentally became a midwife, because I was by this time I did my midwifery, I was a single mother of a 2-year-old, and I was going to move. I bought some land down the coast, and I was going to move down there and save the world down there. And as it happens, though I saw a sign at Westmead Hospital and said, "Do you want to be a midwife?" So I went down. They said, "Can you start on Monday?" So I accidentally fell into midwifery, but it's been what has driven me. And I think, listening to you, Lauren, and Caleb, and some of the words that have emerged about what's driven you, like passion. As you can see, as I talk, I'm so passionate about the work that I do as a midwife and previously as a nurse, that I've always been really curious. So I haven't accepted things as they are in the clinical field, and in particular in my different roles as a midwife, which went from, as Carolyn pointed out, I was a home birth midwife and a team midwife. And, sometimes you look at the political and clinical chasms that can exist, and it's like, it's got to be better than this. And you can see sometimes, and most recently in the press, you see some of the birth traumas that women are reporting. Well, they've been around for a long time. Some of us clinicians have got a lot to answer for, and I think we've got a long way to go in looking at how we do our work. Then being a disruptor and being bold about that. So, I've stood up for my beliefs, and I think it was beautiful you talking about advocacy, Lauren, because I think that's what is at the core. As a mother of 5 daughters and a son, they're a blended family. I grew 4. And then also as a nana of 10, nearly 11 grandchildren. So important that their beginnings of life are held so sacredly and safely, and there's kindness. So collaboration's been enormous, bringing together different people that who are on your side, willing to support you, that are part of your tribe, and also the belief in yourself that you can do it. That that whole imposter syndrome. You've got to have a commitment. And I think I've tried to step away from midwifery, and it keeps dragging me back in, and here I am now. And I think overall a kindness, anyone in your sphere of influence, you just don't know what's going on in their life. And that little girl from Mount Druitt, I saw a lot, I experienced a lot, and even over my life, I've experienced a lot. And I think kindness can go a long way. And here I am now in this role, and the number of nurses and midwives that I've taught or had contact with, the number of women I'm coming across, the number of people, the managers, and is even Donnams that were my students in midwifery. It just, that kindness and that collaboration and that connectedness can make a difference in how you can do your business every day. Now, in saying that, just down the bottom there is I ended up being a clinical midwife educator, and then a consultant first in practice development and research, and then in clinical governance. But where you can have all those wonderful qualities that that will help you to be successful, you've also got to look out for the pitfalls. So here I was, a CMC, really interested in research and wanted to do something. So I was collaborating with a team of researchers at a certain tertiary referral hospital. And then we was suggested at a conference, and I was talking about the difference, why are women having rectal Voltaren when they're having perineal repair? Not something that I'm particularly, I'm interested. It's an important topic, but it's not what gets me out of bed of a morning is pain relief. And I'm a midwife, so we're trying to look at, and as a former home birth midwife, trying to look at optimal birth and women's choice. So I ended up starting and undertaking a randomised controlled trial as I hadn't done much research, I hadn't done my PhD. So I took on a randomised controlled trial with $20,000. It was a drug trial, $20,000 naively given to me by the local health district. And if I think back, the advice and the support, while well-meaning, it would be not what I would give my clinician-scientists today. It ended up being a 4-arm randomised controlled trial with 4 different drugs, and we're across 4 different sites. That's not where you start in research. So I learned a lot about colour coding in doing clinical trials. I learned a lot about data management. I learned a lot about ethics. I learned about scraping together the ability to be able to get the research done. I also still had the undying support of senior academics and clinicians in supporting this trial. However, we could never get it. It was so hugely, we need such a big sample, we could never get to power, and time ran out. And so I've been able to present it because I think we've got to honour those women who invest in us as researchers, but we've never been able to get it published to date. So do your research on who you're working with. Look at what programs might enable you as a clinician scientist. So whether you need to go and do some more work in statistics or epidemiology or qualitative study, but also find experts in that field and go and talk to them. Explore what the nuances are likely to be. So that's some traps for new players. So I did my master's, and I started my master's when my second daughter was 18 months old. She's now 32, and I said to my husband afterwards, I said, I am never, if I ever mention that P word, kill me. But obviously I went off and at University of Sydney undertook my PhD, and these are a couple of academics and nurses and midwives I prepared earlier. These are my 2 oldest daughters. One's graduated from her midwifery degree, and the other one was graduated as a nurse, Bachelor of Nursing and Business, and now has got an MBA as well, working in the business field rather than nursing. So just gloating a little bit here. So spreading the love around in the family. But from my PhD, so what drew me back into the PhD was something that I was passionate about. I'd been working as a CNC. That research I talked about was just a small part of what I was doing. I think if you can do work that you love doing every day, you never really, it makes it so much easier. Anyway, while I was at the Northern Sydney Local Health District, I had the pleasure of working with the fabulous Professor Sally Tracy. She came in as our clinical professor. So I learned a lot about being a conjoint clinical chair from her and balancing the act between universities and the local health districts. But she is a classic disruptor, and we went in, and there was a Ryde hospital had significant problems with, which is just west of North Sydney, for those of you not in New South Wales, so not far from the harbour, about 15 kilometres from the centre of Sydney. Anyway, it was really floundering and had some big clinical governance issues. So with investment from sponsors at the top, so if you want to do some research and you haven't got much money, go right to the top of wherever you can and get sponsors and executive sponsors to come on board, because sometimes when you're trying to bring in evidence or trying to change things, you're going to come up against some conflict. You're going to come against resistance. People are frightened. What they've always known is disappearing. So you have to sometimes have some big, bold investment from up the line and alongside you, and you still have to remain bold in this. So we set up the Ryde Midwifery Group practice with obstetric, midwifery and management support. It was under the gaze of, it was very nerve-wracking, under the gaze of the Minister of Health at the time, because it was precarious. I mean, it's the first time in New South Wales anything like this had been set up. So we set up through clinical governance. The current CEC CEO, Professor Michael Nicol, was working alongside us, and we used really rigid risk assessment to ensure that this service was safe, buttressed, and that everything was prepared and ready to provide care as one of the first freestanding birth centres. So from that, evaluation came out of it. Ultimately down the track, we did a preliminary one. I think that that in itself is bringing all the stakeholders that is important that is for your project to succeed. And if you can get funding, you know, that's good, and that's usually your grants. We were lucky that this was, as a CMC, this was part of my role, so I was very blessed. So I say, if you can do something that you're doing every day and then review it and research it, even better. So anyway, off I went off to another bigger role doing clinical governance down Sydney Southwest, which, you know, was also having its own clinical governance issues at the time. That was a very important role in really lifting more of the cover on what the importance of processes, the importance of education, working together, transparency, making sure if you're putting something in, you're buttressing it in, and you're putting an evaluation framework around it. So coming to the end of that iteration, my beautiful Professor Sally Tracy won a grant and said, come and do your PhD. It was like, yes, we've done all the work around caseload midwifery at RIDE. So off I went and did my PhD over at the Royal, where we transformed with I called it the fluid logistics team, which included obstetricians and managers and staff, admin staff, and midwives. And, you know, once again, it wasn't always smooth sailing, but, you know, just sticking to your course, your commitment, inclusion, honesty, transparency, it enabled that service to be transformed to, at that time, 40% of the women receiving care from a midwife that they know in labour, and being cared for through antenatal and postnatal care, called caseload midwifery. And you can see from that, we ended up with publication in The Lancet. We did a prospective cohort study at the same time, and now this work underpins the highest level Cochrane systematic review. It's one of the included studies in the high level evidence for the caseload or continuity of midwifery care in reducing preterm birth rate and health and wellbeing outcomes for mums and bubs. So they say this model, if it was a pill, every woman should have it, because it provides that beautiful relational care and it improves outcomes, and it also saves saves costs. So this work led me on to some postdoctoral work. And so I ended up in a fellowship with the Poach Centre for Indigenous Health. So that was where I was able to really start to fully explore working with Aboriginal and Torres Strait Islander women and babies. But also during that time, that what came out of the RIDE redesign and the evaluation is that we underpinned that work as one of the controls for risk management, the National Midwifery Consultation and Referral Guidelines. So I was worked with Sally and the team on the first iteration, and then was a project officer for the next two. I think we're now on an executive level with this, enabling other younger midwives to come through and do more work, and teams doing work. So it's become much more collaborative approach, rather than with a few. There's been teams of people, teams of midwives and obstetricians contributing to this. So out of your work, you know, your clinician-scientists, you can produce some absolutely amazing things that can really underpin work into the future. It's like that buttressing. You have to have those strong foundational works that enable your work to be continued and to be examined. So with that, the guidelines underpin, and the caseload model and the continued care models now underpin many of the Aboriginal and Torres Strait Islander services. So as a postdoc, I was able to build on the work of Carolyn Homer and her team. She did the first evaluation. This is an Aboriginal continued care model in Southwest Sydney. So I was able to, through my fellowship there, go back and examine the data using a different lens to what Carolyn and her team had previously done a few years before. And also we just let us know that the women felt culturally safe and the outcomes were great. Once again, this is something that would underpin the future work that I've been doing with birthing on country. So I'm just going to flick through these. These are this body of work underpins many of these. So this freestanding birth centre, and this the maternal satisfaction survey that they have voted that the freestanding birth centres were the number one place in 2015 to give birth. That was just a random survey. That these guidelines and the models of care are now in many of the guiding documents that underpin midwifery practice and midwifery education in the country. And it also is mentioned across, some of our new quality improvement processes in Safer Baby Bundle, in reducing stillbirth, and in promoting women-centred care, which is core to caseload care. I'm just I'm not going to go through all of this, you can read that yourself, but we still know that the health of Aboriginal and Torres Strait Islander mums and bubs are disproportionate, and in this day and age it's a shame in our country. So the models of care that we examined, caseload underpins birthing on country models, and that is one initiative to try and close the gap for maternal infant health. So birthing on country is a metaphor for the best start to life for Aboriginal and Torres Strait Islander families. And it's not just caseload midwifery, but it is one of the core tenets. It's about all of the care that the women need to wrap around them to enable whatever life circumstance they're in, that they can actually be safe, have their needs met, and that they can feel culturally safe. So often it involves their cultural case managers, liaison officers, and also education officers. But it's a socio-cultural, and because when we don't have these models of care, the women keep telling us there are socio-cultural and spiritual risks that it can be just as dangerous as having clinical risk. So out of the work from some of my colleagues, I've then gone on and done been on grants on birthing on country, the BOOST study. And one of the frameworks that guides this work now is the RISE framework. So we've redesigned health services based on continuity of midwifery care. We've got to invest in the workforce. We don't have enough midwives, and I'll show you a slide in a moment. Strengthening the families. Many of the Aboriginal and Torres Strait Islander controlled services are very good at providing these wraparound services where the funding allows it. But also, what's the big change is enabling First Nations communities to be experts in their own community on what their families need, because they will know what needs to be done, and people just need to listen and support them in that. And that's what Birth on Country has been doing and producing fabulous outcomes. So this is just an example of the Birthing on Country. So Molly Watergooga Research Centre at Charles Darwin University. I'm an affiliate there, and that's where this research is based. So we're finishing the BOOST study, which, as you can see, Women are on the south coast. They're a service now that is has been funded for the first freestanding community-controlled birthing service, and funding for ongoing staffing for the next 7 years. So this is how, from little things, big things can grow. So even though, as a clinician-scientist, you're not in the middle of it, but the work you do gets built on, and that your commitment and your endurance helps others to be able to realise their dreams. But also, in this case, Birthing on Country actually saves lives. So some of the work I'm doing now is, well, we all know in a post-COVID world, we just don't have enough midwives and nurses anywhere. So, it's even more dire in the First Nations workforce. We know that to have sustainable services, in particular regional and remote areas, we need Aboriginal midwives. We're still disproportionate. It's only 1.3% of midwives identify as Aboriginal and Torres Strait Islanders, and many of us get sucked up into the vortex. We're not delivering the clinical care. We're up the line, but we're trying to foster increases in these numbers. So there are many different ways that we're looking at, and this is the focus of some of the research I'm doing now, is looking at how we can increase that workforce right from high school. And we've just recently done and you'll see in a moment, we was a part of a Pathways project with the Nurse and Midwives Office in New South Wales, where we had an integrated model where we had post-school leaving Aboriginal people that were employed 0.5 for 3 years, They did their Cert 3, and they also went off, many of them did their enrolled nurse certificate, but there was a maternal infant package bolted in, and that they had cultural and clinical mentors, but they were embedded in the maternity services. They were there for 3 years, and the cross-cultural exchange was been phenomenal. So the outcomes, we now have 3 bachelor students, almost finished actually, some of these, 2 midwifery and 1 nursing, so, and 8 completions of a diploma of nursing with maternal infant skill set. And we only had 1 withdrawal, so it was quite a successful model. So building on that, we hope to be able to socialise Aboriginal people into the workforce. We need to work greatly on ensuring it's culturally safe for them. You know, we've got a long way when it comes to systemic and organisational racism in the systems, but I'd like to think that we're going in the right direction. You can see down the bottom there the partners in that project, and so we're hoping to translate some of that here at Western Sydney Local Health District.
Donna, I'm really sorry to do this to you, but we've probably only got a minute or so. I'm so sorry.
Okay, so I'm just going to briefly mention the Aboriginal Health and Medical Research Council. I always like to mention this. I sit on the ethics committee. If you're going to be researching with our mob, make sure you look at the guidelines, because when it comes to us, engage the community, follow the guidelines, get your ducks in order, and be very considerate of all of the priorities. So there's some of my projects at the moment. So investing in the First Nations workforce, addressing asthma inequities amongst Aboriginal people. Now, beautiful Gomeroi Gangle breastfeeding study, and on the advisory committee, this is the longest longitudinal study of Aboriginal childbearing women and their babies in the country. It's my mob, and I've been invited on the advisory committee, and originally collecting biosamples and looking at markers on any of the neuro and hormonal influences on the well-being, the outcomes, and then ongoing health and well-being of Aboriginal and Torres Strait Islander babies. But we're currently, from that data, we're now looking at breastfeeding, because we know that could be a fabulous solution to better health and well-being. So this is just to say, look, thank you, Maraba, Indayu. That's in my language, Kamilaroi. And I just want to, these are some of my beautiful sisters who, many are on the board of the Rodanthi Lips Indigenous Trust, raising money for Indigenous midwives, students and midwives. And that's on the right, that I think, Carol, you've even come and walked with us from Redfern over the University of Sydney one year. And some of us at the ICM, which is what we raise money for, some of the women and men that can't get to conferences. So I just wanted to give that a bit of a plug. And here we go. A little girl from the Druid. And my daughter gave me this card at a significant birthday a few years back, and she just touched me. I climb Mount Druid. So I think the takeaway is just believe you can do it. Just because people around you don't think you can, have your commitment, your passion, your drive, get friends, be nice. Not all the time. Sometimes you've got to be a bit tough, but, you know, like in the nicest possible way. So I think that's it for me. And sorry, I went a bit over.
Donna, thank you so much. That's just fantastic presentation. And I love the sense of journey that you've taken. I really found that fascinating. And I love the take opportunities, practice kindness, do work that you love doing. And thank you for reminding us about the AH and MRC. I think really important for not only in New South Wales, but for researchers across the country. So I do hope you'll stay with us, because I know there'll be some questions. There's a question in the chat about mentoring, which we'll come back to you on. And you've covered a lot of that through the session. So thank you so much, Donna. Really lovely presentation. I'm going to hand over to Claire. We've made an executive decision not to have a break. So over to Claire.
Yes, thanks, Caroline. And can I just say how much I've enjoyed all the speakers until now. We will just keep continuing through in case people have ducked out of something else to attend the session as per the program. But of course, feel free to take a comfort break, you know, or do whatever you need to do to get a cup of tea and be comfortable, everyone. Just a reminder that you can post your questions in the chat box. We'd love to hear what's running through your head and give our speakers a chance to respond to that, or to use those in the panel this afternoon. So our next speaker is Professor Jennifer Faraday, or Jenny. She's the Clinical Professor of Midwifery at the University of South Australia and the Rosemary Bryant AO Research Centre. Jenny was previously the Executive Director of Nursing and Midwifery for 10 years at the Women's and Children's Health Network and has held a range of other senior nursing positions in both the public and private sectors. Her research interests are person-centred care, consumer voice and experience, models of care, professional scope of practice and advanced practice, and she works across a range of qualitative methodologies in a collaborative way. So thank you, Jenny.
Hi everyone, I'm just going to put my presentation up. Can you see that okay? So I first of all would like to acknowledge that, has that come up? Okay.
Not yet, Jenny.
Oh.
At least I can't see it.
Okay, so
Alex may be able to help.
that come up now?
It looks like it's coming now, yes. Just need to put it in the presentation mode and should be all good.
Fabulous, got it.
Well done, great.
So hello, thank you for all the speakers before. You've been incredibly inspiring. So I'd just like to begin to acknowledge that the land that we're meeting on are the Aboriginal lands. And I'm on Gomeroi land, and I'd like to pay respect to Aboriginal peoples as the custodians of the land and to the elders past, present and emerging. So I'm going to talk to you a little bit about high impact research. Now this is about life as a clinician-scientist, and so I have a slightly different slant on those. I have come over to this role fairly recently. So I'm going to talk a little bit about being an executive as well as being a researcher at the same time. So just a brief overview of my journey. I'm a registered nurse and a registered midwife, and we're talking about 40 years, which I don't like to admit too much, but that's the truth. I've had many clinical and education leadership roles in both public and private hospitals, and I've always continued in higher education. And then in about 2000 or in the late 90s, I went and did a PhD full-time. That was because, unfortunately, I got multiple sclerosis, and I had to make a change in what I was doing. But as you can see, I'm well and healthy now. And a PhD seemed a good way to go. I will say that it is, to be able to do a PhD full-time in 3 years is an amazing thing to do. And I just have so much respect for the people that I supervise and for probably most people that you've heard speak today, doing PhDs over a long period of time, whilst working full-time, juggling families and everything else. So I just want to say that the people that do that are passionate and tenacious in that and what they do. So after I finished my PhD, I went over into a research role at the Women's and Children's Health Network in Adelaide, in the Department of Nursing and Midwifery Research and Practice Development. And many of you might know Professor Philip Derbyshire. That's who I worked with. He was a great mentor, a great orator, as many of you would know, and a really fabulous person to learn from. And so that gave me a really great number, about 5 years in that role, where I was able to do research with nurses and midwives. I'm predominantly a qualitative researcher, but love doing collaborative research, love just doing research at clinical level, and then also to be part of bigger research grant-funded projects. An interesting thing in that time was midwifery group practice actually had some of its infancy at the Women's and Children's Health Network. And we decided to do an evaluation. And there was a group of us, and including professors of midwifery. And so we did a study and did this evaluation. And when we showed the executive at that time, they shook their heads and said, oh no, we need to get an external review done to be able to do an evaluation. And they weren't appreciative of the research at the time. Anyway, we decided to audit it, so to speak, and actually the wonderful Caroline Hyman did that and came back, and we published from then on about the MGP journey and the satisfaction of midwives and the satisfaction of women. And as we know, these many years later, it's still very high, and it's an excellent model of practice. So I continue doing things like study with paediatrics as well as midwifery. And some of the things were like midwives, how they balanced their work life, working in an NGP model, and things that midwives still actually struggle with a bit today. I used to do in that role a lot of research around change. So changes that the Executive Director of Nursing and Midwifery wanted to put in, I actually did the research basis for that. And so gradually, over a period of time, started acting in her role, and then actually got the role of Executive Director of Nursing and Midwifery. So I had that for over 10 years. But during that time, I was an adjunct associate professor at the University of South Australia. And recently that led to the Professor of Midwifery role. When I was first approached by the university of whether I wanted to think about that and apply for the position, originally I thought they wanted a joint role. And I looked into it, and my EDON role seemed overwhelming as it was, let alone the professorial role on top of that. So thankfully, people had published in this area. So I was able to look at some of the Canadian literature that just said, it's actually not sustainable. These joint roles, one gives out, and probably the person was not able to, keep both those roles at the level they wanted to. So, we discussed that, and then I came over as a clinical professor, really an industry professor to UniSA. So I think my first important part of re-entering research to the full degree was to be part of a research concentration, and that would be one of the first pieces of advice that I would always give. And for me, it's the Rosemary Bryant Research Centre at UniSA that has a focus on nursing and midwifery research, and has been, a wonderful group of people to work with. So high impact research. What I just thought I'd start with is, what is the high impact research measures? Now, a lot of you are researchers and you know these very well, but I would guess out of 200 people, there'll be people that didn't quite know about these. So I'll just be quick to say that the Research Excellence Framework talks about a number of key measures, and there's three I've got here. One is the quality of the journal. And that's about, it's called an impact factor, and it's the number of times selected articles have been cited elsewhere. So the higher the impact factor, the more highly ranked the journal. And I've got there a cover of Nature. Nature has a number of journals, and they've got a very, very high impact factor. And if you have an article in Nature, it is meant to be the pinnacle. So the next thing they do is the quality of the publication of articles, and that is about the times cited for your own article. And now they've introduced metrics, which is basically alternative metrics. So it's really interesting now that they're starting to look at not only just citations, about tweets, where they're liked, they're shared, bookmarked, viewed, downloaded, mentioned, favourites, reviewed or discussed. So this is the new wave coming through of social media, and how does research affect that? And then the last thing is what they call personal, or sometimes for a department, the H-index, attempts to measure a researcher's total output based on citations over an entire body of work. So they are the things. So if you are going for promotion, or somebody is looking at you as a researcher, that's the sorts of cold measures that they would have. Now, I'm not saying that they're not important, because if you're doing research, and you aren't able to communicate it, or you can't disseminate it, and people aren't using your research outcomes and then translating them into practice, then there's probably not much use doing the research. But I also would like to challenge these measures, especially when it comes to health, because often for the people that are at the end of the research, you're looking at mortality, morbidity, and quality of life, and they're often the things that are not measured. So I went and had a look and thought, well, let's have a look at our two big bases, ARC and NHMRC. And it was interesting because you can see from that definition that the second dot point talks about key metrics, but the first one is about a demonstrable contribution to the economy, society, health, environment, quality of life. And the key metrics such as article citations and the ones I mentioned before, such as media mentions, should complement each other to build a case study of impact. So the next one was the NHMRC research impact position. And again, you'll see that they talk about verifiable outcomes research with knowledge, health, economy, and society that have anticipated effects of the research, the impact of the research, that it's been adopted, adapted for use, or used to inform further research. So research impact is always also, this is interesting to mention this, research impact also includes research that leads to a decision not to use a particular diagnostic, treatment, or health policy. And being in healthcare for a long, long time, stopping doing something is very hard, even when the evidence is there. There's some real custom and practice. And there you can see that NHMRC talk about the impact can arise from such outcomes as changes to knowledge, policy, practice, drugs, devices, etc. So we've got measures in there, but we've got research impact statements that actually start talking about research and the impact on people themselves. So what have we got in research in health, and what is the impact? Well, the obvious ones are reduced mortality and morbidity. Improved quality of life is something, and quality of life measures are important, and we know there's actually quite a few tools that you can use. But again, quality of life is also something that lends itself to qualitative research of how people feel about things. So we have research about more effective treatments, around less side effects, reducing the risk of errors, because we know that's a big problem in healthcare. We also know that there's lots and lots of good, but errors can actually have a huge effect on someone's life, and even death can be the result. This one I thought was interesting, was research into reduced costs for the same or improved outcome. And again, that's something, whether you call it smart thinking, lean thinking, or whatever paradigm that you use, that research needs to look at how we can have reduced costs, but we still have the same or improved outcome, and to challenge that status quo. Obviously, preventing chronic illness is another one, or managing chronic illness. And certainly in public hospitals, they talk about low value care. Again, some of these are debatable, but they will not fund certain surgeries or treatments in public hospital if it's deemed to be low value care. So you can do all the research you like, but it doesn't do much unless you actually translate that into practice and bring about evidence-based care, or whether it informs public policy or decision-making for health priorities. And so translation of research, it's talked about, it's built in quite often to grants, and I would argue that would be one of the most important measures that's hard to pick up just from citations, but to actually pick up where has that research actually been translated into practice. So researching within health organisations, I saw this quote and I actually really loved it because it's how I would think, that research has impact if the people or the organisation involved somehow do or experience or understand differently as a result of their interaction with the research. Fairly simple, but that's essentially what you want to do. You want to spark that critical thinking, spark someone to think about how they could do something different. I think the other thing, and we've had some lovely examples earlier today, is that it's really important to include the consumers as partners in research. And more they're leading the research agenda. And so certainly Lauren talked about a 50-50 group of consumers as well as clinicians to talk about what was the most important research priorities. And I think that's a really fabulous way to go. The other thing is service evaluations. That's something we're not good at. We're good at putting in new services, changing services, but we're not very good at evaluating these services. And again, I don't just mean having a review. I think reviews have their place, importantly, but let's actually use research methodologies to evaluate services and the success of services. And so evaluate their impact, importantly, their return on investment, and, you know, to make sure you have some KPIs about what you're doing so you know what to measure, key performance indicators, and to know what to stop doing. Again, one of the hardest things to do is stop doing something or doing something a different way. I think it's really important to collaborate with universities. So this is where this, the notion of the clinician-scientist actually comes in. I think it's can be through clinical chair roles, it can be through clinical academic roles. Medicine's had them for many years. Nursing and midwifery and allied health are starting to pick up on them. But I think it has a long way to go with clinical academic roles. And I will just say that there is the nurse practitioner course at UniSA, which I was thrilled when they brought in, was to have, these are teaching academics, but they also do clinical as well. So they maintain their, you know, the integrity and their credibility with the nurse practitioners. And I think the other thing that's really important as part of health organisation research, and certainly it's monies that I've been on panel chairs and for research grants and that, to give money towards developing disease registries, you know, tissue banks and data sets, because you build them up. I mean, Western Australia is some of the best examples of that. You can have research coming from that for years that has that longitudinal and quite broad view with it. So I've got here, I've used clinician researcher, but it's actually what I did. And I thought I'd just share with you briefly. What I did is in those 10 years as an EDON, to be able to keep going with research. And a lot of that was enabling research for others. So applying for and supporting others to successfully gain research grants and scholarships. So I ask you to think about your organisation, and is there somebody there to support clinical staff to be able to do that? To collaborate and be part of research. So I had that wonderful Women's and Children's gave me that opportunity. I've mentioned vaccinology because that was probably one of the biggest areas, which was with Professor Helen Marshall, who conducted the big meningococcal B research. But she included me as a nurse as well as an executive and having a research background. And we just did some simple studies as well, what difference an SMS can make to families coming in and getting flu shots. And also you might know about nudge research, which is the theory of what can alter people's behaviours that's easy and cheap. I think it's really important that higher degree research students have industry supervisors, and that's very strong here at University of South Australia, but I'm sure in a lot of universities. So to be able to marry industry with that. And I certainly was an industry supervisor.
I'm so sorry to interrupt you, Jenny, but probably just have a few more minutes to wind it up, please.
One last
Thank
slide.
you so much. Thank you.
That's good. So evaluations, as I talked about, service evaluations. And the other thing that's really important is research culture, to make sure you showcase research, have presentations, enable research opportunities for nurses and midwives, journal clubs, research interest groups, committees, and a really important thing is to encourage in your university and in your organisation to have adjunct roles in it. So that is my take on what is high impact research. Thank you very much for having me.
Thank you so much, Jenny. That was fantastic, and especially to get your perspective as both a clinician researcher and as someone who's been involved at the executive level, setting up some of the systems that support the clinician researchers. I guess just one question for you is, what advice would you give to early career researchers who are trying to work out which topic or field in nursing midwifery they should focus on?
So I think one of the important things is what interests you. So you've got to have that thirst for knowledge. What have you noticed that's important? And then I think mentoring is really important, or being part of a research collaboration where you can join with someone that can help shape that and shape your question. I always encourage people to do higher degrees when they start doing research. You know, make it part of your work. So what you're doing at work, do as a higher degree at the same time, and then you're able to start on your research journey. And I think it's there is a lot of researchers, but there's a few that aren't, that are very generous with their time and very generous in making sure that the people that they mentor, you know, do get to be first author, do have that opportunity to be able to build those research metrics.
Fabulous, great advice. Thanks so much, Jenny. So keeping in a South Australian Zoom environment, by coincidence only, I would like to introduce our next speaker, also from South Australia. So Greg Sharplin. Greg is the Research and Strategy Manager of the Rosemary Bryant AO Research Centre and a Senior Research Fellow in Uni SA Clinical and Health Sciences. Greg's primary research interest is in investigating the work environment and the conditions for healthcare workers and how these factors affect occupational performance and well-being, so productivity, quality, engagement, job strain and burnout. Thank you so much for joining us today, Greg.
Thanks, Claire, and I'm hoping you can hear me and that everyone can hear me, and I will have a go at sharing my screen. Let's see how this goes.
Yes, I can definitely hear you, and it looks like your slides are coming up now.
In presentation mode. All good, Claire?
That's fabulous.
Brilliant, thank you. Yes, so bit of a change up, I suppose, in the presentation here, and something that we've been pursuing with colleagues across both Australia and New Zealand in establishing the Australasian Nursing and Midwifery Clinical Trials Network. And first, just to acknowledge the traditional owners of the lands that we all meet on today. I'm on Donna land, and I pay my respects to elders past, present and emerging. So I suppose the brief on this presentation was to promote the network and to encourage people to engage with us, to learn more about it, and hopefully to become members, because we see this as an important platform from a nursing and midwifery perspective to I suppose, grow the capacity and capability of nursing and midwifery-led research, and to, I suppose, linking back to Jenny's presentation, the ability to conduct trials or research of high impact, where conducting a study at one site could then potentially lead to a multi-site, multi-state, or potentially a study that is conducted across national borders. So I'll kind of work through this broad overview of the presentation and provide some background info data as well. So just to, I suppose, to reiterate that we established the Nursing Clinical Trials Network to accelerate the growth of nurse or midwife-led trials or clinical studies in both Australia and New Zealand. And it sounds kind of nice in theory, but it's certainly a challenge. We were established in 2020. We kind of emerged just as the time of the bushfires ending and COVID beginning, which made it a little bit challenging in terms of, firstly, meeting, although Teams and Zoom certainly helped with that, but also in terms of people's attention being distracted elsewhere, especially nurses and midwives working in clinical settings, the health department, and with universities, because obviously everyone was feeling the strain, especially of the early days of COVID. The rationale, or part of the rationale for building this is based on, firstly, that clinical trials attract a lot of funding through Category 1 grants, and in particular, when they are large trials over, for example, over $1 million, then 50% of the funding will go to a network. So networks are very successful attracting large funding, and hence nurses and midwives who are looking to run large studies, potentially based on this evidence, would be best off associating or aligning their studies with a network. And the other rationale is that looking at, and these data are provided by the Australian Clinical Trials Alliance, that of 200 grants that they looked at that were funded, only 9 that we could see listed here had gone to nursing midwifery specific research. So there's a real gap in, given that 60% of the workforce approximately is made up of nurses and midwives, but this is certainly not 60% of the research effort. And importantly, the translation of evidence into practice not only has a benefit to consumers, it also has a cost benefit to the health system. And so the more that we can conduct these high quality, high impact studies, even if they're not all implemented for every patient, they will still return a cost saving. And probably finally, just to pick up on some of the interests that kind of extend outside of this, from me personally, extend outside of the ANMCTN, but that having good quality care in the work, or having research embedded in the workplace improves the quality of care, reduce waste and reduce harm, and also importantly helps to retain the quality of those staff in that system. So yes, just to, I suppose, to reiterate the points that I've raised earlier, including the bottom one around recruitment and retention. The network, as part of setting it up, thought a good place to begin is to conduct some reviews of the literature regarding the number of studies that have been led, or the number of RCTs that have been led by nurses and midwives across Australia and New Zealand, published, and we went back as far as 2000. You can see there that there has been, I suppose, some modest growth over the years, but it's certainly not at the numbers of studies that have been published by other professions. And I think here, mainly of the medical profession, who are, I suppose, much better, I suppose, and historically better coordinated with respect to running RCTs and running them through networks. I suppose just to also comment on the types of studies that were being conducted, they were mainly in the areas of treatment and prevention. We also looked at the topics that they were conducted in, and this is to give us a sense of where we have potential gaps, but also where we're doing quite well. And naturally, in terms of midwifery, reproductive health and childbirth is quite high, as is antenatal care. For nursing, it was in cardiovascular and stroke, but there was quite a blend there across a number of, I suppose, disease or condition streams. In setting up the network, there's obviously a lot of already great information and resources out there, and ACTA's probably done a lot of work in supporting networks, ones that are already established, but also ones like us that are emerging, by providing and kind of synthesizing this information. So we didn't have to look too far to work out what are the things we need to get going. Number one on the list was an executive officer, and so we began by I suppose working together on pooling some funds to be able to employ an executive officer, because that's so critical to helping to build that momentum. And as I was saying before, these are just some of the resources, and there are others available that we've been able to draw upon to help, I suppose, guide the structure, the governance, the activities of the network in its first 3 years. We've been quite successful. I think members of the executive committee would agree that the engagement we've had from across the universities has been excellent, and perhaps shows that they also recognise that this is a gap and an opportunity for their nursing and midwifery staff, and can see the small investment that they have made. Or when I say it's small, it's always difficult to be able to justify and continue to invest in activities like this, because working with university budgets is not always easy. So we really respect and thank those deans of the schools of nursing and midwifery who have supported the network to date. And we also have the colleges, ACN and ACM, who have led their kind of partnership support to it, as well as ACTA. So this is just a list, I suppose, of covering off those founding university partners, and the New Zealand universities have kind of all met and decided that they would all join together. So that was excellent. So we have the 6 universities from across New Zealand, and we're working with them on how do we kind of build their I suppose, capabilities in the clinical trial sector, because one thing they acknowledge is that relative to Australia, they tend to have a much stronger weight in the qualitative research space, and few, I suppose, leading researchers or clinician researchers conducting clinical trials. This is a list of the members of the executive committee, and it's actually an old photo, an historic photo, and you can see Claire there in the top right-hand corner. So we've had great engagement from executive committee members. We also have a strategic advisory committee, which is growing, and that's made up of the financial partners and professional groups of the network, because their voice is very important in guiding where we kind of place our efforts, as well as their networks are important for linking us in with who we need to reach out to with our partnerships. In our first 3 years, we have established that initial governance structure. We've also established a scientific committee, which is, I suppose, it's forming as we speak. But this allows us to conduct initial assessments of people's grants or their trials, which is good for the research community to get some feedback on their design, as well as to get that endorsement stamp, which may assist in the success of their grant. We have a website built, so you can visit, I think that may be the older website link there, but you can visit anmccn.com.au from memory, and you can join as a member. We hosted a summit in Adelaide earlier this year, and we're planning to host a strategic planning day in the next month, which will help with the further planning of the network. And we're in the process of developing up a CRE so we can grow the pot of funding for which we can support nurses and midwives in their clinical trials endeavours. There's a lot of good articles out there that support the rationale and the potential impact that we should be working towards with our network, and we look at these documents closely to pursue that. So potentially looking at this workforce to take advantage of addressing the care gaps that currently exist in Australia. I'll quickly wrap up and say that, as I said before, we're pursuing funding. We've set up an endorsement process, and we also have membership, and we encourage people who are on the line who may be considering joining to reach out to us or just to sign up and see what it's all about, because there is membership content that it's only available to members, and membership is free. You may have received a flyer through your networks. If anyone is interested in promoting, please reach out to us and we will send you some information if you have networks you'd like to promote onto. And so what does success look like? Might be commonsensical, but if we can see an increase in Category 1 funding and the size of the funding for nurses and midwives, and we can reflect back on that kind of review we conducted prior to setting up the network. We can see larger scale studies that potentially have that potential for reach and impact into the healthcare sector. We can see future leaders emerging. We can support and mentor, and we have a mentoring program, albeit small, but a mentoring program for junior clinicians and researchers, and also that we can support these clinical trials and these clinician researchers with respect to a platform that they can leverage to advance their research, their careers, and the impact of their research. I think I'll just leave on this quote here that kind of reiterates that we do need to do something in this space, because as I've presented, it represents an underfunded area, but it is critical to the health of the community, to individuals who are accessing our healthcare services across Australia and New Zealand. So thank you, Claire. I'll hand back to you.
Thanks so much, Greg. That was a fabulous overview of the network, and it is a very exciting time. Just one question I suppose people might like to know, and without naming any names, how receptive have yourself and the Professor Marion Eckert and the network gone when they're sort of trying to advocate for nursing midwifery clinical trials in sort of different levels of government and so on? Has it been an open door feeling generally?
Yeah, I would say that we've had really good engagement from all levels of government. I think it's not necessarily an easy thing to then translate that into funding support from government. That's where the more difficult ask. But we have met with Minister Jed Kearney to communicate about the network, the value of the network, and potentially seek funding. And we got as far as the seek funding, and then we failed. But we got the support, and we raised the awareness with the government around what we were doing. And we're now pursuing with Minister Butler's office regarding a different approach for funding of the network, which is exciting, I suppose, and we'll see how that goes. But importantly, we've also had engagement from some of the chief nursing and midwifery officers from across Australia who are interested in how can they engage and and we have Queensland help on board, which is excellent. So I think that really we haven't had too much pushback from that perspective, which is an important step. And also just to mention the colleges as well, you know, they've got members, they're kind of, I wouldn't say competing in the same space, but they want to work out how they can work with us because they can see that potentially can value their membership.
Fabulous, Greg, thank you. And I'm sure we all appreciate the work that you and the organisation are doing to advocate and lobby for increased resources and visibility of this vital part of the sector. So thank you for coming to speak with us today as well. So it's time now to move on to our panel. We have three amazing panellists, and just to change the tone a little bit of this event from formal presentations to a more of a relaxed and possibly humorous, I don't know, session. So I'll introduce our three panellists to you. First of all is Distinguished Professor Patsy Yates. Patsy is the Executive Dean of Health from Queensland University of Technology. There she is. Thank you, Patsy. And we also have Rebecca Hyde with us, who is a clinical midwife specialist at Royal Women's Hospital and a lecturer in midwifery at La Trobe University, and she is currently undertaking a PhD. And last but not least, we have Tricia Clyden, who is a nurse practitioner at the Queensland Children's Hospital and Research Fellow at the University of Queensland. And thank you to all our panellists for joining us today. We're sure that you'll have some real world great reflections and examples. The first question that has actually come in on the chat is, how can we change the narrative with executive in health services to quarantine time for clinician researchers to undertake research, but also to build their own research literacy? So I don't know who'd like to take that first, but feel free to jump in. I'm sure you've all got different experience and ideas about this.
Waiting for each other to utter words of wisdom.
You're
so
all too polite.
Yeah, I'll just a couple of words. I think the main thing is that as managers, you've got to understand, they need to understand the value of the investment in your precious time, whether it's delivering care or whatever. What's the value that that's going to return to the organisation, to the patient care? And I think we've just got to get really good narratives around how that investment of your precious time and resource is going to return in a whole range of different ways, in terms of improved quality of care, in terms of improved efficiency. And you've got to get really sharp at sending that message, because I know that a lot of executives don't have a lot of time. So, you know, you've got to communicate that very clearly as well.
Yeah, time is definitely an issue. Is that something, Tricia, you've come up against, trying to cut through all the messages to get your message through?
Yeah, definitely. And I think one of the things that we can take to executive is that as a nurse practitioner and even a clinical nurse consultant or a nurse manager or a clinical nurse, that we model our time around the strong model. And the strong model does suggest that there is varying times of dedicated towards research for clinicians of different levels. So there should be different components and time dedicated to, you know, research, education, clinical management. So that does make the complete picture, not necessarily, not that that necessarily translates into actual practice, but you can certainly put forward a case that it is going to improve your clinical outcomes and the clinical outcomes for the patient. But it is very difficult to actually magic answer on how to do that, but continue advocating for dedicated time within that model.
Thanks, Tricia. And what about you, Beck? Is this something that you've seen any examples of where executive have realised that it would be a great investment to free up some time for research and practice innovation?
I think in some ways where I work, I'm very lucky. We actually have a professor of midwifery who is a joint appointment between the Royal Women's Hospital and La Trobe University. So I think that having that role and they sit in with a lot of the executive meetings, so advocating it straight to the executive team is really helpful as well. But I think it's also got to come from kind of the ground up as well. So like our midwives on the floor need to be aware of how important research is and kind of agitate and try and get involved in different things as well, and advocate to their managers who then can advocate up as well. So I think it's kind of got to come from all levels as well.
That sounds like a beautiful utopia that we do need to work towards. I like your idea about you've got to be in the room where it happens, so to speak. If someone's not in the executive meeting, then they're not going to get a chance to hear about it. Patsy, I know you've had a lot of experience in trying to bring together the academic side of research to sort of lobby within health services for clinician researchers. Have you seen any particular models work well?
Look, I think that the models that first up, it's got to really be that you've got to have that shared sort of vision and shared understanding, the common goals. And so the models that really work well is where there's a very clear understanding of what we can do together, and that together actually we're going to get better outcomes. And so I think there's that piece. I think the other piece, and I really do pick up on Beck's comment, is that like oftentimes I have conversations with like senior nurse executives, you know, who are, yeah, we've got to do this, what, but then when it's sort of the different, you know, where health is very hierarchical, isn't it? And then when it gets down the sort of, you know, and then I'm the nurse manager and I've got to actually deliver on certain sort of, you know, staffing requirements, you know, patient care, etc. And so it's recognising that actually, while we've got senior support, that actually we've got to really have something that benefits all levels of the organisation if this is truly going to work. And so, you know, the models that I think are where there's tangible benefits that the nurse managers on the floor can see that interest them, so that they are getting better patient care, more efficient patient care, the staff are more satisfied. And then at the senior executive level, that they've actually got the KPIs that they want to do, you know, a workforce that's growing, improvements in their sort of data that they're looking at. So I think, you know, Beck's comments about multiple levels there is critical to that as well. But the vision and shared commitment is really key.
Perfect. I guess all three of you are here because you've overcome a lot of these barriers in the context of a health system and an academic system that hasn't perhaps been set up perfectly to facilitate nursing midwifery clinical research. I guess, Tricia, could you reflect sort of how you've overcome some of those barriers to get where you are now?
Yeah, I think probably for me, the biggest thing to overcome is, or that to help you overcome the barriers, is to have a great support network. And to do that within the clinical and academic setting, you need the support network from both sides. So to have a clinical team that you work with who you trust and really find it easy to collaborate with, and know that they support the research that you're doing, and that you can leave a lot of the clinical work to them so that you can continue with your research in a setting where you're not being constantly interrupted, is incredibly important. But also from the academic setting, having the support of researchers who understand the clinical role that you have. And I do find that within the clinical and academic, for me personally, my clinical tends to always overtake the academic. So if there is a clinical situation that comes up, I would do that in preference. And I always get very anxious on a day like this, where I know that I have to be here at a certain time, but also know that at any time something else could pop up. But that's something that you have to get over yourself, and really trust the support network that you have around you, the clinicians that you have around you, that they can handle things without you. So it really does involve a large team to support the clinical and research work that you're doing from both sides, I think.
Yes, and how to ensure that those clinical colleagues feel that, you know, you having the time off to do research is a value add to them, I suppose, rather than, you know, is it fair that, you know, our colleague goes to a conference and talks about their research while we're here manning the floors? Beck,
yeah, I think it is
that something you... No, go ahead. We're keen to understand, because I think, as Patsy said, you know, getting support. So there's always support right at the top, but, you know, making sure that it's, you know, actualized on a day-to-day level in your peers and local managers, you know, that sometimes can be where the message gets a little bit confused.
Yeah, because it's that two-way relationship. So the clinicians that you work with, they understand that the ideas and clinical work that you're going to bring back with you is going to be of benefit to the whole organisation and the clinical outcomes of the patients. So it is a mutual trust and respect of the undertakings that you're both doing. So I think that's where they see the benefit of supporting you in the endeavours that you're doing as well.
Fantastic. Beck, is that the same sort of barriers that you've had to overcome, or is there something else you'd like to highlight for us?
Probably quite similar to Tricia, but similar to what Tricia was saying, having support of the people that you're working with is really important. So I was really, really fortunate that my manager in my clinical role was really supportive of me going into the research position, and then later on when I joined into the midwifery lecturing position as well. So if I didn't have her support, I probably wouldn't be able to very easily maintain a clinical role as well as maintaining the other ones. And just having that flexibility where all my managers understand that I am working across a few different things, and so I need a little bit of flexibility at times as well. But I think as well, getting into research, I had to be really proactive about it. So I actually sought out Dalla Forster, who's the professor of midwifery at the Women's, with one of my colleagues, and we sought her out and put forward to her an idea of what we wanted to try and help to improve antenatal care for women, but also staff satisfaction with delivering pregnancy care as well. So we actually were really, really proactive in what we thought was going to work for the organisation to help make it better for women and for staff as well. But you need to be able to know who you need to go and talk to and how you can get to them as well. So we were just really fortunate that we were at a conference that she was at the same time and struck up the nerve and went and spoke to her. But sometimes finding the right people can be really tricky as well. So I think trying to engage as much as possible with your profession. So attending conferences is a really great idea, because you get to hear about other research and different things that are happening, but then you can actually link in and meet them as well and try and form connections to help with getting your foot in the door as well.
Perfect. Yes, I like, was it, someone said, if you feel the fear and do it anyway, was that Lauren? That's a perfect example of just going and cold calling someone or meeting someone at a conference and asking for support. It sounds great that I'm so happy you've got all that support, but what happens when managers leave and turn over and the kind of deal you've organised at the start sort of starts to look a bit shaky and falls through? Any Beck or anyone like to talk about that? Sort of how do we build a bit more stability into these arrangements, as opposed to, I suppose, boutique, bespoke, sort of negotiated local agreements that are very much based perhaps on personalities and existing relationships?
I've been really lucky, and all my managers have actually stayed the same at the moment, but one of my managers is about to go on maternity leave, so I will be testing how that goes in the coming months. But I think it's just having that open dialogue for one thing, and making sure that everybody's on the same page and can see the value in what I bring, having multiple roles to that particular role as well.
Great. What do you think, Patsy? Do we actually need a statewide or a national sort of framework, or like so many beds equals so many hours of research time? Do we just need to have some rules around this, that everyone's on the same playing field? Not that I'm putting words into your mouth.
No, but I think you're right. I think that it is about both relationships and about structures and systems. And if you can sort of get that balance right, you know, what are the right frameworks and structures, etc., that, you know, that support and enable. And I always used to work with a person, you know, did a lot of work for government and sort of talked about sort of getting it like entangled into the systems, that it's almost like too hard to undo, you know, that and that it's entangled in a way that it's clearly part of the system, part of the organisation, and people wouldn't dream of it not being there. But at the end of the day, it actually is also about relationships and about doing good work, because you know, we all live in really pressured environments at the moment, and if, you know, parts of our work are not actually adding value, then they will be questioned. You know, that's just the nature of what we, you know, the work that we do today in any sort of industry, I think. So I think, you know, those would be the three things I was continuing to communicate the benefit and the value of what you do, really good relationships with people about, you know, so that they're gaining. And then, yeah, and I agree, Claire, it's the advocacy piece that Greg spoke about. You know, what are the structures and systems, both at an organisational, but also perhaps at a policy level, you know, in our industrial frameworks, for example.
Sounds great. Patsy, I'm just reading a few comments from the chat, which I might just read out. And if any of you feel that there's something you'd like to comment on, you can yell out. The first one is, what do you think? Oh, they're commenting that if you wear scrubs when you work in clinical and your own clothes when you're doing research, that's a very visual way of flagging that you are not available or you are meant to be doing something else. Another comment about disparity in disciplines, and I suppose that is something that it would be good to talk through, is, you know, that obviously medicine has a longer history of successfully combining, not for everyone, but for many people, combining clinical and research activity. And that seems to be valued in the health system. Any suggestions on sort of what we can learn or how we can get a sort of more even playing field for nurses and midwives in that regard?
I've noticed with my medical colleagues, it's kind of an expectation that they will have some form of research involved, at least while they're like in the program for obstetrics and gynecology, that it will just be part of their role. It's just an accepted part. But I think for nursing and midwifery, potentially having some more clearly defined things where it is a bit more available as well. So whether that's getting it put into our EBAs, that there is some form of research role that involves protected time for our midwives and nurses, or I think we kind of need to think outside the box, but also kind of establish a way to make it more accepted that this is just part of our role and not just that we're there to help the doctors do their research, that we can actually lead our own research as well.
Yeah, I agree. And I think that research comes in all shapes and forms. And where you mentioned, Claire, about the formula for, you know, how many hours per patient beds, and the comment about the time to do research. If you're talking about an implementation form of research, then that's incredibly important. That's something that is going to improve patient outcomes. And I think that's something that nurses do very well. So I think sometimes in my particular practice, we do a lot of the level 1 studies, but then we don't actually have the time to implement it well into our clinical practice. So I think that if there was more dedicated time for nurses to really follow through in their research, there would be greater outcomes for the patients. And that's something that we could potentially demonstrate as a measurable outcome to the executive. And so there'd be that value seen in nursing research. I think more and more nurses are undertaking higher degrees in research as well, and that's going to be seen as something that will improve the highlight of nursing in research. And I think it's not something that's going to happen really quickly, but the more we push and the consistency in forging ahead with nurses as a very useful tool in research, and not just doing research but implementing it into practice to improve outcomes. Hopefully at some point executive will see the value in that, but I do think like Patsy was saying, there's multiple layers to push this endeavour on, and that really does come from systems and the executive and the unions as well, so that we do end up with time to do what we need to do, and we're not just doing it in our own time, so that we can achieve our own personal and professional goals.
Yeah, here, Trisha, that sounds like a great manifesto. How, I guess, important to you guys has been your journey with mentoring, and would you like to comment on, you know, what characteristics or what particular aspects practically of mentoring have really helped you? We might start with Patsy, even though I'm sure you do all the mentoring yourself these days, but do you recall early on what young Patsy benefited from?
Wouldn't be doing what I'm doing today if it wasn't for really, really critical mentors. And I think, so for me, I think, you know, early in my career, it was, you know, things that, like we're all here talking today about what the world could be like with research, but it was actually like the sort of the generation before me who actually could see, well, we need nurses to be doing research. We need nurses, and people who actually sort of dragged me kicking and screaming to, you know, as a mid-20s, I'd much rather be out sort of at the nightclubs back then, but, you know, dragged me to these sort of events that were professional events where they were talking about research in nursing. And so it's really people who actually take you out of your comfort zone, who can see what you have to offer in the future, has been really critical. And then I think since then, though, it's really mentors, you know, that later on in my career, the mentors that I really appreciate are the ones who will really challenge me. And, you know, again, it's probably still taking you out of your comfort zone a bit, but people who given you opportunities, people who challenge you to sort of do better all the time, I think are really important qualities.
Fabulous. Thanks, Patsy. Beck, your mentors, have they all been midwives? Have they been local people? Have you had virtual mentoring? Anything that you reflect on that's been really useful?
Yeah, most of my mentoring probably has been a bit more informal relationship mentoring kind of thing. And that has really been really important to kind of push me to where I am today. Like I would never have thought that I would be doing a PhD if it wasn't for my mentors being like, yeah, you can totally do this and you should definitely do it. Even like the roles that I've taken on in my research career, like at the moment, I'm co-project coordinator for a really big RCT, which I never would have thought that I would have been doing when I first started research. So that's been such a big thing for me to help build my confidence and to push me into doing things that I probably wouldn't have thought that I was ready for, but my mentors thought that I was. So very important.
Yes, so important. Trisha, what do you think's helped you in terms of getting you supported as you've come along on this journey of research?
I have to be careful what I say because one of my mentors is chairing the session. But similar to Beck, I didn't think I would be doing my PhD. I do remember when I started on this journey having a coffee with Claire and talking about vascular access and how I was going to change practice, because a lot of what was happening in my clinical workspace was not evidence-based and actually quite old techniques and practices. And I, in my head, was confident that all I needed to do was to become a nurse practitioner and I would solve all of those issues. And Claire's like, no, you should do a master's in MPhil, do a master's in nursing research. I was like, no, I really want to be a clinician. I'm going to, push ahead with this nurse practitioner gig. Did that and didn't really change a lot of practice, but continued to be supported by a number of really great nursing researchers and just participated in little small research studies that they were leading. And still, I think somebody else was saying earlier that they said after they'd done this study, they were never going to do the PhD, not going to do that. And I remember saying that multiple times myself, but here I am. And I think I'm here because I did feel incredibly supported by my mentors. It's something that I didn't think I could ever do, but just with the support and confidence that they built in me through mentoring me, I did feel like I could do it. I mean, don't get me wrong, there's still days that I think I can't do it, but it is having the regular support of the mentors who continue to build you up and remind you that you can do it. And I think it's about finding the right mentor, someone who understands you and you understand them. It's no point having the most amazing mentor, but you don't get on with that mentor. I think you need to have a relationship that's mutually respectful of each other. And regular meetings, schedule regular meetings in. And I think, sometimes we slip with our meetings, but there's always the ability to catch up on email. So having an understanding of, if you aren't able to catch up regularly, what's the alternative plan? Having someone who's flexible to working with your work and professional, personal life as well, I've found quite useful.
Thanks, Tricia, and thanks for acknowledging me. I know you have many, many successful mentors, as well as my small role in your journey. So and it's a privilege to be there. Here's a question from the chat is, how important do the panel think being involved in associations are in terms of providing support and mentoring for conducting research? Beck, did you want to speak about your thoughts on that? Any organisations you've been involved with have perhaps facilitated doing your research or the research mentoring, or have they been more of a clinically focused kind of engagement?
Probably more
education focused
engagement, more with associations, but like I'm a member of the Australian College of Midwives, so engaging in like conferences they have and study days and webinars and that sort of thing, like that's essentially how my career started in research, was going to one of the Gippsland Victorian conferences and meeting up with Donna there, and that's kind of how my research career kind of started. So I probably wouldn't have necessarily engaged in those conferences without being a member of those associations. But other associations, I haven't really engaged in specific research ones as such at this point in my career.
Sounds good. Patsy?
Yeah, I think too, my career journey has been really very much helped by involvement in professional associations in a number of ways. One is that it sort of opens doors, gives you opportunities to sort of get new networks and new partnerships, to include things in sort of policy and practice and guidelines. So there's a number of different reasons there. But I think from a research point of view too, there's one of the groups that I'm, work with a bit at the moment that I find most helpful is some of the clinical trials collaboratives. So I'm lucky in the oncology field, we've got lots of clinical trials collaboratives, and being able to go to those meetings where they bring out the sort of the concept development workshops, the peer review programs, they endorse your proposals and give sort of, statistical advice, health economic advice, whatever it might be. So finding any of those networks that can do that for you, it absolutely improves the quality of the research that you do. And I know that that it's when they report, the group recently sent out their annual report, and the success rate they get with their grants is really extraordinary as well, because they're really helping people to do quality. So if you can find a group like that, I find that they're very helpful.
Yes, I'd second that, and I think ACTA, the Australasian Clinical Trials Alliance Association, so many organisations, I get them all mixed up, but they have a wonderful website which lists all the clinical trials collaboratives and clinical trials groups. So yes, totally second your point there. And if there's an area that looks related to where you're working, feel free to email them and ask them how you can get involved, because they're super supportive, pipelines to building research. Tricia, your association involvement has been far-reaching, not just in Australia. Has that, in reflection, how has that been in terms of supporting your research and the translation of results and so on?
I think I'm probably similar to Beck in that I haven't really reached out to the research associations, but more remained connected within the clinical associations. But it is a very good way of networking, because even at the clinical meetings or associations, you have a mix of clinicians and researchers. So it's a fantastic way of meeting people who you will like to partner with in the future. And by being involved in various associations, as well as the support of my mentors and academic colleagues in Australia, I became involved in assisting in this guideline writing for the infusion nursing standards, which is an international guideline. So it does have far-reaching impact on your work, and it also means that you can be involved in at the first-hand level in developing those standards and ensuring the quality of the standards, particularly if they are being written largely by clinicians, providing that next level of academic support to ensure that they have that academic rigour is quite important. And again, these are the type of opportunities that I wouldn't have had if I hadn't engaged in not only national networks but international networks.
Yes, great point. We're going to wrap up shortly, but I guess I'll just ask our panel if they would like to offer one piece of advice to an attendee of this meeting who's very early in their career. They're just starting to dip their toes in this world of research and clinical research. What advice would you give them as they embark on their journey as a clinician researcher? Might start with you, Beck, if that's okay.
I think my one piece of advice would just be to make sure that you put yourself out there. Research, particularly in nursing and midwifery, is rather small. So if you aren't putting yourself out there, then you're not going to get the opportunity. So you kind of need to be proactive with it. But I think as well, research is really, really rewarding. I find it so good to be a part of research and then being able to bring it into the clinical space and being able to talk to my fellow midwives about the results that have come out from studies that they've helped to collect data for us for, and all of that sort of stuff. So I do find it really rewarding, but it can also be quite challenging in a different way to what your clinical role usually is as well. So, but definitely worthwhile.
A glowing endorsement. Thanks, Beck. Patsy, what advice do you have to offer?
I think that's come through in some of the presentations this afternoon, really, good collaborators, really good collaborators, and, will sustain, you through, and we'll keep pushing. I think, good mentors, and so it's not one bit of advice, I'm giving a couple. But the other thing I think is, it sort of, as someone who's now getting sort of towards the later part of one's career, the thing I would sort of encourage people beginning is to be ambitious. I think, we sort of, you've got to start, and we sort of, you've got to learn and all of that sort of stuff along the way. But actually, we can make such a difference through nursing and midwifery research. And I think that we shouldn't underestimate that. It's not just think big, and because I think, we have an obligation to improve, the health system and outcomes for our community. So I just encourage people to be ambitious.
Great advice. I love it. And Tricia, a piece of advice for a young clinician researcher starting out as a nurse and midwife.
I think a lot of it has already been covered, but research is difficult, especially if you're trying to incorporate it within your clinical role, and it does take a lot of energy. So if you want to be successful or succeed in a particular area of research, then you have to be incredibly passionate about it, because it is going to take a lot. You're going to have to give a lot of yourself, and you will come up against barriers. There's there's no way to sugarcoat it, the fact that nursing research is still forging ahead. We are still not there in terms of having the support from all executive and even all other clinicians. So you really do have to be passionate about your topic so that you can continue to forge ahead even when you feel like you're not going to be able to succeed. And with that passion, try and ensure timing as well. If there's a particular policy that comes out that you think aligns with the particular area of research that you're passionate about, that could be the right time to really spark the idea within executive that this could be a good thing to support. So I would say passion and timing.
Great advice from all three of you. And I'd just like to thank all of you so much for joining us today. It's been really invaluable. And we all know how busy clinician researchers are. So again, we've made you more busy, and we acknowledge that. But we do think that's really valuable for the audience to have you with us today. Can I just check if you can see my slides there? No, it's gone into a black hole of doom. Let me have one more try. Otherwise, I'll see if I can get some assistance. How's that? Looking better? I might just get you to share that, Alex, because I can't see it coming up there. Okay, I'll just ask Alex to put those up for me if that's okay, and I'll just talk them through. So thank you to our panel once again, and next slide, please. So I just have my chance now to thank our sponsors and supporters. So this seminar today has been put on with the support of the Australasian Nursing Midwifery Clinical Trials Network, and we thank Greg for joining us today. Next slide, please, Alex. These are our platinum sponsors for the overall Life as a Clinician-Scientist series that we run through the Academy, and we thank them very much. And next slide, we have our gold and premium sponsors. And again, without their support, we wouldn't be able to offer these series throughout Australia. Next slide, please. So this isn't the last event this year. You're very welcome to join us for the next 2 events this year, although they're not directly aimed at nurses and midwives. If you come to them, you will hear, as I have been to other ones, you will hear the same issues. Sometimes in nursing midwifery, we think that all of these problems are only ours, but I'm unfortunately here to tell you that they permeate all the health disciplines. If you're lucky enough to be available for the Victorian one, that will be in person, so a good opportunity for networking as well. And we will be running another series of these next year. Next slide, please. All of these sessions have been recorded. We also ask you to give feedback. If you pull your phone out and take a picture of that, it'll take you to the website with a form for feedback. Please don't comment on my inability to share my slides. That would be appreciated. So we also will have these sessions recorded and available for sharing. So if you have some colleagues who couldn't make it today or registered and then something came up, like they had to go and look after a patient at the last minute, then by all means, these will be available. So I think all of our panel, again, I think it's been a wonderful time sharing. We always say you can't see what you can't be what you can't see. And I think today we've seen some really fabulous, diverse, but all amazing presenters who've really generously shared their stories, including their successes, but also what they've learned along the way to get there. This is a really exciting time, and the Academy has recently released a roundtable vision report about the state of integrating research into the health system. So I encourage you all to go to the Academy's website and download that report. It's got some very practical and very useful recommendations that will enormously benefit nurses and midwives as they continue to improve patient experiences and outcomes, and that is gaining a lot of traction with government at varying levels. So thank you all today. My apologies that we've run slightly late, but I hope it's been a great value for you. I'm sure it has, and thank you to the support team behind the scenes, Claire, Vaz and Alex today, who've helped us to make this happen. Have a great evening everyone, and goodbye.